Hello everyone and welcome to today's session. This is the last and fifth and the last episode of this webinar series. The topic is miscarriages and the latest updates about the subject, and speaker is Dr. Nasser Al-Asmar. Hi Nasser.
Hello Vikram. Hello everyone.
Hi Nasser. Hello.
Hello.
So
Hello
we have a
everyone.
thank you. We have a very decent audience out there who have joined us this today. The topic is all yours, miscarriages and the latest updates about the subject. But Nasser, before we begin with the deliberation of yours on the topic, I would like to take some time of yours and would like to introduce you to the audience.
Thank you.
Dr. Nasser Al-Asmar is a scientific advisor and embryology director at Igenomix headquarters, which is in Valencia, Spain. Nasser received his bachelor's degree in pharmacy and a master's degree in biotechnology of human-assisted reproduction at Valencia University, Spain. He got his PhD in biomedicine and biotechnology with the topic importance of the chromosomal analysis of the products of conception, which relates with today's topic, by next generation sequencing, that is NGS, and RACGH techniques for an appropriate reproductive advice at Valencia University, Spain. He was laboratory manager at Igenomix USA, Miami, Florida, from its opening in 2012 until January 2016, when he took over the position of scientific advisor, first in the USA and now for Spain and Latam. Nasser Al-Asmar has over 10 years of clinical and research laboratory experience, first at IVI Valencia Clinic, Valencia, Spain, at the pre-implantation genetic diagnosis laboratory. After that, at Igenomix Valencia, Spain, at the pre-implantation genetic screening laboratory, and then at Igenomix USA, Miami, Florida. In the clinical setting, he has extensive experience in the study of chromosomal abnormalities in embryos, that is PGTA, and spermatozoa using RACGH technology and fish. He is also currently developing these same studies by NGS, that is the next generation sequencing, analyzing products of conception as well. In 2019, Nasser Al-Asmar had lectures in international conferences in several countries, such as Argentina, India, Nigeria, Kuwait, Japan, Hong Kong, Spain, about all different topics in reproductive genetics. So we have the whole sort of encyclopedia with us today pertaining to NGS and microarrays. So thank you very much, Nasser. Nasser, thank you. This is an extra thanks to you because I know, we all know you are on holidays and still you spared your valuable time for this web-based series and the topic of the day. I thank you profusely and immensely for being present here today. Thank you very much, Nasser, and the session is all yours.
Thank you very much, Vikram, for the kind introduction. Yeah, I'm in vacation, but I'm really happy to be with all of you. For me, it's a pleasure to share always what we perform, what we do. So be sure that it's a pleasure for me to be here today. So don't worry about that. And thank you, of course, to all of you to be here today and this topic about miscarriage, the latest update. As the title says, I'm going to talk about the miscarriages. I'm going to talk about the indications, the causes, and at the end of the talk, I will explain our own results in order to show you how important it is to analyze the products of conception after a miscarriage. So let's start with the introduction. You all know that the incidence of a spontaneous clinical abortion in general population, it's around 50%, but most of them around 80% occurs before the 12th week of gestation, which could be considered as a biological barrier. And later on, we will talk about this biological barrier. And chromosomal abnormalities are the most frequent cause. So chromosomal abnormalities or aneuploidies are related to alterations in the number of chromosomes that can cause spontaneous abortions and chromosomal abnormalities in newborns. We do know that more than 50% of the miscarriage in the first trimester, whether spontaneous or following ART, are the result of chromosomal abnormalities. And it's important to know that this increased up to 60% among women who have undergone ART. So I will explain later why it's important that we analyze this kind of products of conception so we can give better chances to the couples in a proper cycle, either if it's ART cycle or trying to get pregnant spontaneously at home. I would like to show you also this graph because in those days, we did this analysis between 2010 and 2014, analyzing different embryos for PGTA, that going through PGTA, for patients with 2 miscarriages or with 3 or more miscarriages, because at that time, there was a discussion between if a patient with recurrent miscarriage should be considered after 2 miscarriages or after 3 or more miscarriages. You can see that we divided the graph in 2, under 38 years old and over 30 years old, with 2 and 3 or more miscarriages. So if you take a look to the data, the percentage of normal embryos, percentage of transfer, gestation per transfer, implantation rate, or miscarriage rate were similar in both groups, 2 or 3 or more miscarriage. Same thing for older patients older than 38 years old, that you can observe exactly the same for the normal embryos, percentage of transfer, gestation per transfer, implantation rate, and miscarriage rate. So in this case, we will define a patient as a RPL patient with only 2 miscarriages. Also, it's important to check this paper from Professor Coutet in 2015, talking about the management of patients with recurrent pregnancy loss. What they did is to analyze the frequency of abnormal results in more than 1,000 patients, and they divided in 2 prior losses, 3 prior losses, or 4 or more prior losses. So first, they checked patients for evidence-based results, and they define evidence-based tests, those tests based on current literature, including parental karyotypes, evaluation of uterine anatomy, tests for lupus anticoagulant and anticardiolipin antibodies, and tests for TSH and factor V of Leyden. As you can see on the graph, they found 41% of abnormalities in patients with 2 prior losses, 40% in patients with 3 prior losses, and 42% in patients with 4 or more prior losses. So there's no statistical significance differences in between all the patients. They as well did this investigative test that they call tests that were under research at that time, including antiphosphatidylserine antibodies, luteal progesterone levels, cultures for species of mycoplasma and ureaplasma, factor II prothrombin, and prolactin gene mutations. They found exactly the same. There were 20% abnormal for 2 prior losses, 22 for 3 prior losses, and 21 abnormal results for patients with 4 or more prior losses. So again, was not statistically significant. If we put it together, we will have results such as 61%, 62%, and 63% respectively. So at the end, there's no statistically significant. So they were telling us again that with 2 losses, we should consider a patient with recurrent pregnancy loss. So despite knowing a multitude of etiological factors, some abortions remain of unknown case. I can tell you some of the causes, such as genetic causes, immunological, such as autoimmune, antiphospholipid syndrome, autoimmune, like killing immunoglobulin receptors, anatomical, endocrinological, such as insufficient corpus luteum, PCOS, diabetes, Hematologic causes like non-antiphospholipid thrombophilias, causes such as infections. We do know that chronic endometritis could lead into a miscarriage, so it is important to check the patient for a chronic endometritis, as well as a dysbiosis on the microbiome. We know that a microbiome dysbiotic can lead into not only implantation failure, but also to a miscarriage. And obesity is a cause as well of miscarriage. It has been discussing if these patients with obesity has higher chances to have chromosomal abnormalities in their embryos, but well, it's still not clear. But what I'm going to focus today is obviously to that part that we are in Igenomix are experts, or kind of experts, and this is going to be the part of the chromosomes. Let me show this study from Robinson et al. When they studied first miscarriage, they studied for a patient, and then the patient had second miscarriage, and they studied again for chromosomal abnormalities. What they found is that those patients that were euploid or normal result, that in their study were almost 60%, when they had a second miscarriage, the chances that this miscarriage is normal again increases up to 78%. But then when you check the abnormal results, trisomy or other aneuploidy, you can see that in average it was almost 40%, but if we take trisomy, for instance, you have 26% chances to have abnormal. At the very beginning, you have almost 60% to have a normal miscarriage. But then if you have the first one abnormal, the chances to be normal, the second one, is going to decrease. And the chances that you have another trisomy is going to be increased in 20% as well. So then if we analyze the first miscarriage, we do know how to go. Obviously, if it's euploid normal, we do know that there is nothing to do with chromosomal abnormalities, and we can check another things. But if it's abnormal, we do have in mind that chances to have a second abnormal miscarriage are going to be higher. So then we do have to do an analysis with the patient, check for age and everything to see what should we recommend to the patients. This paper is also a pretty good one, and I would like to explain to you. This is also from Professor Coutet, the group of Professor Coutet. Popescu is the first author, and they show us at the very beginning, they perform in 100 patients the classic ISRM workup study. So what they had with this 100 patients, it's 55% were normal, so they didn't know what's going on after this workup, and 45% were abnormal. Those were 4% had a abnormal parental karyotype, so they recommend genetic counseling. 19% had an abnormal anatomic evaluation, so they target surgical correction. 9% had abnormal endocrinologic evaluation, so they target to medical correction. And 70% had altered autoimmune factors, so they went through aspirin, heparin, calcium, vitamin D, and so on. So this is the regular RPL workup for the ASRM, and this is what they found. So they show us in that paper 3 different strategies to identify the cause of RPL. So first one is to do the ASRM RPL workup. Second one is to perform the chromosomal analysis of the product of conception. In this case, they used 24 chromosome microarray. And the third one that is the most interesting, because they put both together. Obviously, if you put more techniques together, we are going to achieve better results. But it's interesting because with this putting together the analysis of the product of conception, chromosomal analysis, plus the ASRM workup, you're going to get almost 95% of results. Obviously, they are going to be abnormal, but you do know what happened with this miscarriage. And let me explain to you something that this is really important. Usually, we as a scientist, we don't like to talk about money in our presentations, but I think it's important because obviously more patients are going to get benefit if we do know how to handle their tests, because their tests are associated to a certain money. So we should know what should we do first in case that we cannot do everything. So in this case, this group did two different approaches. So first approach is do first the ASRM RPL workup, and then for those patients that were normal, perform the chromosomal analysis. And the other approach is do first the chromosomal analysis of the products of conception, and those ones that were normal, then do the ASRM RPL workup. So let's see how it then ends up. The first example, look at this. Here they performed first, as I said, the ASRM RPL workup, and the total cost for this 100 patients that they analyzed was $330K. I'm talking in American dollars. So in those cases that they got an abnormal, well, they can get obviously abnormal or normal results. In those cases that they got abnormal results, they already know what's going on, and they have the total amount of money, 150K. But for those ones that were normal, you have to do the analysis, chromosomal analysis of the products of conception. And this is gonna take 38K more. So this 30K plus the first ones that they did it for these normal patients, it's gonna be 220K. And the total of the cost doing first the ASRM RPL workup, plus then for the normals, the POC analysis for the chromosomes, it's going to be 367K. Let's go to the other opposite way. Let's do first the chromosomal analysis, the products of conception. So this would take for this 100 patients, 70K. Again, this could be normal or abnormal. And in case of abnormality, we will have 47K. So for this 67% of patients that were abnormal for the chromosomal analysis. So for those that were normal or diploid in those analyses, you have to perform the ASRM RPL workup evaluation. So then you need to add 110K. The total for this part would be 130K. So the total for this approach would be 178K. If you compare both, it's clear that doing first the analysis, the chromosome analysis for the products of conception, and then performing the ASRM RPL workup evaluation would be half of the price than doing first the ASRM RPL workup, and then for the normal ones, perform the POC analysis. So I think it's clear that if we want to do one, we do know which one to do. If we want to do both, we do know what is the path in order to follow. So at the end, they proposed this diagram for the analysis of products of conception in patients with recurrent pregnancy loss. First miscarriage, there's no action taken unless clinically indicated. And then at the second miscarriage, you have to obtain the product of conception and do the chromosomal analysis. If those ones are aneuploid, then you have the results, so there's no further evaluation. You already know what happened. If you got as a result an unbalanced chromosomal translocation or inversion, then it is recommended to perform parental karyotypes in order to know if the miscarriage was because the embryo inherited translocation or inversion from the parents. And if you got diploid POC analysis, chromosomal analysis, then you go through the RPL workup in order to find other possible options that lead to the miscarriage. So let's start with the cytogenetic studies on spontaneous miscarriage. And these cytogenetic classic studies told us already that around 50% of the results were normal in miscarriages, and the other 50% were abnormal, being the trisomies the most relevant, followed by polyploidies, monosomy X, and so on. So we do know that 95% of the miscarriages are de novo numerical abnormalities. The problem that we have with these classic cytogenetic studies is that there is a cell culture failure in around 42% approximately of the cases. And in the literature, we have ranged from 20% up to 80%. So sometimes when I talk about this topic, some physicians tell me, no, Nasser, it's not 80, it's even more. I don't get never resolved. So this is a big problem. And also that there's around 30% of the cases of false negatives because maternal cell contamination. When you get a result of normal eggs, normal female, you don't know if the results comes from the mother or from the fetus. So let's compare the conventional karyotype versus molecular analysis, or in this case, I'm going to explain our experience, the NGS, next generation sequencing. So first one, we know requires in vitro cell culture, and we told before about this 20 to 80% of failure. So our molecular approach doesn't need cell culture. You take the DNA directly from the POC and then you analyze it. Conventional karyotype, you need 1 month in order to get results. With a molecular approach, in 7 to 10 days, you will have the results. And you know that these circumstances for the patient is really stressful. So you would like to have results as soon as possible in order to tell the patient, look, we got these results, so then we can go for this way, for this way. In the conventional karyotype, if you don't have any result, you have to wait 1 month and then to tell your patient that is in front of you that you don't have anything. Results obtained in 58% of the cases in conventional karyotype versus results obtained in 99% of the cases in molecular approach. And I will explain you later on a little bit of this 99% of the cases obtaining results. Conventional karyotype, we have 33% of false negatives, as I said before, results due to maternal cell contamination. There is no false negative results due to maternal cell contamination in our approach because I will explain you what we perform besides NGS in order to rule out maternal cell contamination and all proliferating. And also, the molecular approach has same or even higher resolution than conventional karyotype. Some of the indications to perform a POC in a couple would be couples with RPL or previous aneuploid conception, infertile couples that going through ART, as said before, that in a patient that has a spontaneous abortion at home has around 40%, but patients through ART, this increases up to 60%. So this is really important to check. And also an indication couples with severe male factor. In a work from our friend and colleague Inmaculada Campos Galindo in 2015, she showed us that a couple with own oocytes that has around 60% of abnormal products of conception. In those couples, when the male had severe oligozoospermia, this is like less than 5 million per spermatozoa per milliliter, those abnormalities on the miscarriage increases up to 73%, being 53% when the male had 5 or more million per milliliter of spermatozoa. And also another indication would be couples with environmental exposure to endocrine disruptors, even a male or female. So let me tell you about our experience and what we perform in our lab in order to analyze these products of conception. When we received the products of conception, we performed 3 different dissections. And this is why, because we would like to reduce the chances to get maternal cell contamination. Sometimes you get maternal cell contamination in 2 dissections, but the other one is the good one. So you go for that one, obviously. But we need plus a EDTA, a blood tube from the mother or gestational carrier. And this is in order to rule out the maternal cell contamination or proliferative. Then we perform with the DNA the NGS analysis with the NDA that we extracted from the directly from the products of conception. And if it's needed, we perform also the STR analysis with the blood that we extracted from the dissections, but also from the EDTA blood tube. The NGS protocol, it's pretty easy. It's more or less the same that we usually perform for the PGTA with the library preparation, template preparation, sequencing, and analysis with the iron reporter software, plus our algorithm that was performing in our different labs. So with this NGS protocol, we will obtain, as you will know, different kind of profiles, such as diploid XX on the top, monosomy 45X on the middle, that this is one of the principal problems or most prevalent, and I will show you later, in miscarriage in the first trimester. Or at the bottom, you will have trisomy 15, that also is one of the trisomies more prevalent, and I will show you also the data. But what happens when you get a result as a euploid, either XX or XY? I said before that with molecular, not molecular, but conventional karyotype, you have euploid XX that you cannot say if it's come from mother or from fetus. So then we use the STRs analysis. We use 15 short tandem repeats plus the amelogenin gene in order to rule out maternal cell contamination. And you can see in here, in this example, that on the top, we do have the maternal sample that we extracted from the blood. And on the bottom, we have the fetal sample. Well, we do have what was supposed to be the fetal sample. And I'm telling you that it was supposed to be, because if you take a look, all the peaks or alleles are exactly the same. So this means that this sample doesn't come from the fetus, but from the mother. So if we go with this sample through the sequencer, we are going to obtain a result as a normal female. But this cannot be the result. This would be a false negative. So at the end, the result would be maternal cell contamination, unfortunately. This other example, you can check that we have, again, the maternal sample on the top and the fetal sample on the bottom. And yes, they share some of the peaks or the alleles, because obviously we receive or inherit from the mother, but there are some of them on the fetal sample that are not matching with the mother. And this is because they are coming from the father. So then we do know that this sample, it's obviously coming from the fetus. If we go to the sequencer and we obtain a result as a normal female, we do know that we are providing a result that is coming from fetus, and it's not going to be a false negative coming from the mother. Even though I said that this technique helped us in order to rule out not only maternal cell contamination, but also possible polyploidies. And in this example, you can check a triploidy, because we should observe 1 or 2 peaks. It depends if it's homozygous or heterozygous. But in this case, we are observing sometimes 3 peaks. That this means that miscarriage happened because of triploidy, even though we can go further and check for the gender as well. You can see here on the top bottom that we have the peak for the chromosome X, the peak from the chromosome Y, and you can see the chromosome Y is almost double than the chromosome X. So this is the concentration of DNA, and we have almost the double of concentration of the chromosome Y. So we do know that this embryo arrested, or this couple had a miscarriage because a triploidy, in this case 69XYY. So let me show you our results that we presented at an oral presentation at the AHA 2019, talking about if this is the POC analysis with NGS plus STRs, providing a relevant information for the cause of clinical miscarriage. And let's start quickly with the study design. We analyzed more than 2,500 products of conception. First thing that we did is to analyze different molecular techniques, array CGH and next generation sequencing. And then we observed different patterns and we checked for different analysis. Maternal age, obviously, gestational age, and also oocyte origin. Well, so let's start with the results obtained based on molecular analysis performed, the array CGH versus NGS. And as you can see in our table, there was not statistically significant in between both of them. So when we got these results, we decided to put all together in order to have the total results as far as we do know that there was no difference in between both of the molecular techniques. So total results, I would like to point out, as I said before, that informative results were 99%, but it is important also to point out that inside this 99%, we have around 30% of the cases that we got maternal cell contamination. That means that doing even 3 dissections, we weren't able to find any fetus tissue in order to provide a result. So at the end, unfortunately, the result was maternal cell contamination. as abnormal results in these more than 2,500 POC analyzed, we obtained 53.5% that were so similar as the previous studies reported. Let's go a little bit in deeper and check about monosomies. You do know that usually trisomies leads into a miscarriage on the first trimester. Well, there are some of them that you also know that can go through to a baby born, such as trisomy 13, Plateau syndrome, trisomy 18, or Edwards syndrome, or trisomy 21, Down syndrome. But usually trisomies leads into a miscarriage in the first trimester. And monosomies usually leads into implantation failure. But you know also that monosomy X, for instance, could not only implant, but have miscarriage on the first trimester, or even have a baby born with Turner syndrome. In this case, I would like to show you our results for monosomies, and you can see that regarding monosomies, almost 85% were due to these sex chromosome monosomies, mostly X monosomy. But also, although with very low frequency, we do have some monosomy 21, that is one of the highest incidence, as has been described in different studies. But we also were able to check for some monosomies, such as monosomy 13, monosomy for the chromosome 22. And as far as we know, this was the first time that monosomies for chromosomes 4 and 15 were reported in a product of conception. Let's go with the trisomies. And as we were expecting, the most prevalent trisomies were trisomy 16 with 17% and trisomy 22 with 16%, followed by trisomy 15 that we talked before, we showed the profile, trisomy 13 and trisomy 21. Let's move to the maternal age. So there were no statistical differences in terms of informativity, gestational age, or maternal cell contamination. But obviously, we do have differences in between euploid or aneuploidy. As you can see here, patients that are under 35 years old, the abnormalities are around 45–50% when you analyze the products of conception. Patients in between 36 years old and 40 years old, the chromosomal abnormalities on the products of conception are in the range of 60 and 65%. And patients between 41 and 42 years old, this reach up to 70%. So we do know that 70% of the cases when a patient with 41, 42 years old had a miscarriage is because of chromosomal abnormality. In here, we had a bias. We think that it was a bias, an artifact, because over 42 years old, these abnormalities diminish till 50%. What we think that it happened is because as far as we work mostly with IVF clinics, we receive a lot of TRF, test requisition forms, that at that time were not fully filled, and we missed some patients that went through egg donation program, but when we received the products of conception, it wasn't on the paperwork because any reason, so they put it in this kind of pattern of over 42 years old, and we think that this is could be an artifact of our study, but looks like that it's clear that the higher is the age of the patient, the higher is going to be the probability that the product of conception is going to be abnormal. So let's move also to the maternal age, checking another variables, and you can see the multiple aneuploidy. There is patients below 38 years old, range between 4 to 6%. You can see in the blue bar. But when patients go over 39, it increases a lot. So 8%, 15%, 21%. So over 38 years old is going to increase the chances to have a multiple aneuploidy. Remember that multiple aneuploidy means 2 or more aneuploidies. It's rare to find this in products of conception. If you have multiple aneuploidy, it should be 2. We found few of them with 3, and as far as I can remember, only one had 4 aneuploidies on the product of conception. If you can check the monosomy for the sex chromosomes or the polyploidies, this trend to decrease over the year. Let's move to the gestational age and check, and you can see here that Obviously, the lower the gestational age, the bigger the maternal cell contamination. It's obvious that when you have a patient that has miscarriage with less than 6 weeks, you will have few material in order, if any, in order to analyze. So this is why the chances to have maternal cell contamination are higher with these 6 or less weeks, but you see that it's going to decrease. And when you arrive to 12 weeks, 11, 12 weeks, this is it is arriving to almost nothing, to 0. So there's a decreased percentage of abnormal POC with increased gestational age. Then you can compare here the abnormalities. So if you check patients under 8 weeks, when they had a miscarriage under 8 weeks of gestation, the chromosomal abnormalities and the POC, it's around 50%. If we go between 9th week of gestation and 12th week of gestation, these range are between 60 and 65%. But then it drops almost to the half. And why? Well, we do know that we talked before about the biological barrier at 12th week. So this is why when a patient suffer a miscarriage after this 12th week, we should consider probably prior and other causes of the miscarriage than the chromosomal abnormalities. As we can see, that drops between 60 to 65% to 34%. And also, the lower is the gestational age, the higher is the percentage of multiple aneuploidies. We talked about before multiple aneuploidies, remember 2 or more, and it happens exactly the same, or should happen exactly the same than an embryo. We do know that an embryo with multiple aneuploidies usually blocked or arrested during the development and doesn't reach the blastocyst stage. But in here, it's exactly the same. You can see here the gray bar that is 14% below 6 weeks, and then go 3.5, 3.1, 0, and 0. Let's move to the last part of the results, to the oocyte origin, that we also think that it's really interesting. We do know that usually when you go through an egg donor program, it's because it works better, usually because they are younger patients, and those younger patients generate more euploid embryos. And we can see here that the percentage of aneuploidy was higher, obviously with miscarriage with own oocytes, 55% versus 30% in donated oocytes, but still 30%. So we need to be clear that when you do egg donation, not always is going to be a healthy pregnancy. Increases the chances, but also you have a 30% of the cases when this kind of patient had a miscarriage that are going to be chromosomally abnormal. But also, we check the sex monosomy that was 9% for own oocytes, remember the mostly 45X, and then when you go through donated oocytes, it's increased up to 37%. And we know that 80% of the cases with monosomy for sexual chromosomes usually is due to the absence of the paternal sexual chromosome, unlike the nucleotide of the autosomes that we know that mostly are of maternal origin. And we think that of this, because we remove from here the part of the maternal age, we are having something related with the male that is affecting more on this part to the sex monosomy. And let me show you, we are almost at the end. Let me show you this kind of algorithm that we do recommend in order to know what happened exactly with this miscarriage, if possible, of course. So when the patient has a first trimester miscarriage, we do receive the product of conception and also, as I said, the maternal or gestational carrier blood in order to do the STRs. Obviously, at the clinic, have to do the anamnesis, the paternal age, the number of miscarriages previous, the gestational age, type of miscarriage, and so on. So with the product of conception, we are going to perform the NGS, and let's see the results. If we got normal results, then we have to run the STRs to be sure. Because in our 3-day sections, we get maternal cell contamination, then unfortunately, the final result has to be maternal cell contamination. But if we get no maternal cell contamination, so it is real that this normal result, it is real, we have to go to the RPL workup that we said before, etiologic diagnosis like physical exam, studies such as immunological, endometrial, thrombophilia, endocrine, and so on. If the result of the NGS is abnormal, then let's check for the abnormality. We can have a numerical abnormality, and then depends on also this anamnesis. I'm not telling you that every single miscarriage that get a numerical abnormality, such as monosomy or trisomy, has to go directly through the PGTA. But checking the anamnesis as well, you might go, or you might lead to the couple to go through PGTA in order to avoid another miscarriage due to chromosomal abnormalities, because it's true that it's something that it's not easy to measure, but the emotional burden is something that is really hard for the couples, and you know better than me that when the couples suffer a miscarriage, the emotional burden it's really deep, you know, on those patients. So we can recommend to perform pre-implantation genetic testing for an epilepsy screening. The couple can decide to change the gametes in order to increase the chances to get a normal embryo. Or if the patient doesn't want to go through the IVF techniques, or if there's no need to go through because the age of the patient is young, is the first first miscarriage, so you can recommend, okay, you can go ahead and try to have another pregnancy, but I would recommend to you to do a non-invasive prenatal testing, because we do know that it's not harmful. After the 10th week of gestation, they can perform it in the blood of the mother. They don't need it to do the amniocentesis or anything invasive. So it's gonna be good, I think. So this is if we have a numerical abnormality such as an aneuploidy, trisomy, and you know monosomy. So, but if we have a structural abnormality, then we have to recommend to do a cytogenetic study in the parents, or is the same there, to do the karyotype on the parents to check if they both are normal or they have an inversion or a translocation. If there's de novo abnormality, that means that both parents have normal karyotype, then you can go to the first part. But if they have an inherited abnormality, that means that one or both, that is rare, but it happens, of the parents has an abnormal karyotype, then you can tell your patients to go through PGT-SR for a structural rearrangements in order to avoid those embryos that are going to lead probably to another miscarriage. They can choose to change the gametes. They can change the gamete of the person of the couple that has the translocation or the inversion, or they can go ahead again and you can recommend to do a prenatal test in order to check for this possible problem with the translocation/inversion. So to conclude, I would tell you that the POC, perform POC on the patients, it's really important in order to give an explanation to the patient. They want to know what happened with the pregnancy, why it stops. So they know, they want to know, and we are able to provide an answer and then say, okay, we can go here or there. It's going to be perfect. If it's abnormal, if it is normal, then we will have to consider or focus another possible cause, as we said before, that could be endometrial, endocrine, immunological, thrombophilic, and so on. Also, for the best reproductive advice for a fertile cycle, again, whether it's trying to get pregnant at home or going through ART. And this is important also for obstetricians and gynecologists, because usually when I give this kind of talk, they say, I don't get it, they have a miscarriage, come again, and you will have it. If you have another one, doesn't matter, you will. But when I have sometimes these kind of talks in between the colleagues that are obstetrics and gynecologists and colleagues that also works in reproductive medicine, those colleagues tell, yes, it's really important, because when this patient comes with 3 different miscarriages, for instance, it's important to know what happened with this first. So I don't start from the scratch. I started with some information. And let me let you know that there's important that in a course that we gave last year in the Spanish Society for Obstetrician and Gynecology, they end up that after the second miscarriage, we should perform a POC analysis, but not with karyotype, but with a molecular approach. So this is really important as well. So knowing that the majority of miscarriages are due to chromosomal causes, and once we have a chromosomal abnormality, the probability of having another abnormal miscarriage increases, We considered the importance of this type of analysis and thus be able to assess whether to refer the patient to a specialist in reproductive medicine. And last but not least, molecular techniques combined with the use of STRs, in our cases NGS plus STRs, make it possible to increase the efficiency of the analysis of chromosomal abnormalities of miscarriages compared to conventional cytogenetic techniques, improving the percentage of samples with informative results and reducing the rate of false negatives caused by contamination with maternal DNA, maternal cell contamination. This is all. I would like to thank all my colleagues around Igenomix, all the labs that we have around the world, because without them, I couldn't be here today with all of you. And of course, thank you very much for being here. Please, your questions are more than welcome. Thank you very much.
Thank you very much, Nasser. It indeed was a very fruitful presentation, productive one as well, worthwhile, I'm sure, because you have already received few appreciation messages pertaining to this presentation from the audience. Thank you very much.
Thank you.
I would also like to thank the audience for being here, for being so wonderful and patient. Thank you very much, the entire audience too. So before we wrap up this session, Nasser, we have many questions here. I would like to club the questions and put it to you. Do we have any data which can shed light on the miscarriage rate after the transfer with mosaic embryos?
Well, I think that there are some papers that are almost there in order to tell us what is the rate of miscarriage with mosaic embryos. It would be really interesting for this work that I presented that we find out how many of those embryos, and actually it's something that I guess that we could do it like retrospectively, at least the part of the NGS, but I don't think that there's anything so far telling us what is the percentage of miscarriages that comes from a mosaic embryo. What we know in our hands, in our data, in Igenomix, is that in 2019, with more than 200 embryos analyzed, we had a rate around 6.1% of blastocysts that are mosaic. So the thing would be interesting to know if the people transfer those embryos, what's going on with them, and also differentiating between embryos that are low mosaic, between 30 to 50%, and embryos that are high mosaic, embryos that are between 50 and 70%, because I think this is also going to be different, and also depend of the mosaicism of the chromosome, of course.
And thank you very much, Nasser. Related to the first question only, we have another question. Could mosaicism lead to false positive or false negative results during the analysis of POC?
This could do it, but the thing is that in our approach, we have an algorithm that checks also for mosaicism. So in those cases, if we have any mosaic embryo, we should be able to detect if the mosaicism is higher than 20%. If it's lower to 20%, this could lead into a false negative because we won't be able to see it. So then we would set normal and maybe it's mosaic with less than 20%. But we think that less than 20% should be an artifact, so shouldn't be a problem. The only thing is that you have to be ready in order to analyze mosaicism in order to get those kind of results of mosaic product of conception.
Thanks again, Nasser. Nasser, we have this beautiful comment. This is a comment from the doctor. She has commented that the presentation was very nice. We follow the same, what you have suggested during your presentation. But earlier, during earlier days, doctors used to refrain from excessive testing and wait for 3 miscarriages, because the earlier definition, Nasser, of recurrent miscarriages was 3 or more miscarriages, which has been now reduced to 2 to 3. So now this doctor says we send the couple karyotype and POC from second miscarriage, and if it is third miscarriage, we send the full panel. So now we have another question here. How do you relate? See, you have mentioned in one of your slides about the etiological diagnosis, which could be an underlying disease or which could relate to the immunology of the mother to be, which can cause this miscarriage apart from the chromosomal aneuploidy. Right? If it is not chromosomal aneuploidy, it could be anything else like etiological disorders or
Yes.
immunological response of the mother's immune system towards this foreign hostile body. So how do you correlate immunology vis-a-vis miscarriages?
Well, I'm not an expert in that field. I work in a chromosomal field. So, but as far as I know, they try to correlate with the immunogenesis. The only thing that it's already proven is the antiphospholipid syndrome. That the patient has antiphospholipid syndrome. If you treat this syndrome, the percentage of miscarriage decreases. The rest of them are still under research to see, to know. And the other thing is for the autoimmune system, they are trying to relate the KIR receptors, the killer immunoglobulin receptor, in order to link with the miscarriage. But so far, the only one that is really proven for the immunology, as far as I know, is the antiphospholipid syndrome.
Okay, thanks a lot, Nasser. I'll wrap up this session with this last question. There are articles which say that in patients who have suffered multiple losses, can maternal spindle transfer or cytoplasmic transfer improve the pregnancy outcome in such patients?
Well, I'm not sure about if the problem is something related with the cytoplasm and something that you can change with this. Obviously, it will improve the chances, but I'm not sure that there is a relation if you transfer spindle or cytoplasm that you are going to get better results. So what we observe with chromosomes is that we have more and more that chromosomal abnormalities, but there's a point, I guess, we presented this work in ASRM in 2013, and we said that after 5 miscarriages, there's no increase in chromosomal embryos abnormals, so then should be something else in there. And of course, when you check and you do also PGTA and you have a pregnancy of the patient and the patient already miscarriage is not due to chromosomal abnormality, then you have to do this kind of workup of the different possibilities in order to try to know what's going on. But I'm not sure if doing this kind of transfers of spindle, that I know that it's already proven, but for certain patients, but I don't think it's exactly for the patients with a recurrent pregnancy loss with 4 or 5 miscarriages. I'm not sure if this will improve or not.
Thanks again, Nasser. Nasser, I have some more questions which I have received just now. So this is a question wherein the doctor is asking, do you have a study comparing TLC and PGTA in idiopathic recurrent pregnancy losses in patients below 35 years of age? Is there a recommendation to do PGTA in those patients?
DLC, you said?
Do you have a study comparing TLC and PGTA in idiopathic RPL, recurrent pregnancy losses? And do you think, wherein the patient is having an age of 34 years or less, 35 years or less, is there a recommendation to do PGTA in those patients?
We don't have such a study, but in the case of there's something that, because you know that under 35 years old, patients should have around 65 or embryos that are euploid. So the chances to get pregnant due to chromosomal thing, it's really high. but still around 35% of chances to have an abnormal, an euploid embryo. So in case that you think that there's something that could be related with a chromosomal abnormality, yes, I would do it. Not at the very beginning, because if it's a young couple, maybe you can go with another kind of technique. But if something is telling you that should be related with chromosomal abnormalities, yes, I would do it. Even a younger patient than 35 years old, that again, around the 35%, according to our data, are going to be unemployed in blastocyst stage.
Thanks, Nasser. Nasser, this is a question wherein the doctor is asking for any specifics for collecting POC after medical termination of pregnancy.
Yeah, well, obviously, the way that you perform the recovery or when you take the probes of conception, it's going to be crucial in order to have better results or to have higher percentage of maternal cell contamination. So if you perform hysteroembryoscopy, that you go directly to take from materials from the fetus and you put it in a tube and send it to us, I would say that almost 100% we are going to have results. If you do a regular curettage, the results could be around 80%. We're going to have results, and between 15 and 20% could be maternal cell contamination, because sometimes we only receive gluten mucus. The probability to have a maternal contamination obviously is higher if the patient has to take the sample at home. Usually, you give chemicals, and patient sometimes have the miscarriage at home. Sometimes they get the sample, sometimes it's not. So it's more difficult that we get good results. But let me tell you something, that we are trying to do a study, to conduct a study in order to try to see if for those patients doing this medical termination, if we can take non-invasive sample from the mother and get results from the fetus. Because as far as we are getting prenatal, non-invasive prenatal results for a pregnancy, we thought that we should be able to get results. And this is going to be presented in this ASRM, that is going to be not, as you know, it's not going to be by presence, but we're going to have a study only with a few patients. I guess it's around 13, and the results are pretty encouraging in order to make the whole study, to check if we can take, for those patients that you sent home and take medical termination, take sample from the blood of the mother and then provide results, in order to not to miss this kind of patients that obviously we have less chances to get good results.
Wonderful. Thank you, Nasser. Another question is, what media to be used for collection of POC for NGS analysis?
What we do is regular saline solution. Yeah. So what we ask is saline solution. You cover all the sample, all the tissue, because we try to avoid the degradation of the tissue. If we receive the DNA that is degraded, we cannot extract it. So cover well with saline solution, and that's all. Please don't put formalin, because we are not going to be able to extract the DNA as far as it's going to be fixed. And yeah, saline solution, and then remember the blood of the EDTA blood from the mother or gestational carrier, in order to perform the STR analysis.
Thank you very much, Nasser. Nasser, one more question is there. Should we store, this is a sort of an interesting question, should we store genetic material after first miscarriage, as it is cheaper to store and later analyze the genetic material if the patient is found to be, losing pregnancies recurrently?
Yeah, you can go back and take the sample. Usually this is, we always ask to send fresh, because we try to make kind of studies in order that you freeze the sample, then you send to us, and somehow we sometimes can get result, but most of the times we cannot get anything. So what we recommend is as soon as you have the sample, just send it to us in fresh. If you cannot send it because, for instance, it's a holiday or it's a weekend and you cannot send by courier, please put on the fridge between 2 to 8 Celsius degrees to keep fresh the samples, because the biggest problem is the degradation of the sample. Again, we from time to time try to do some studies in order to analyze those samples that were freeze, but it's not working properly. So we do not recommend to do that.
So this is no option, right?
No, so far it's not. Hopefully in the future, because it would be really interesting if you can keep the samples, and if patient has the second miscarriage, just send both together, or if the patient has the third, you send it together and we analyze it. And this is something that we should keep exploring in order to provide it. But so far, this is not an option.
It was wonderful, Nasser. Thank you very much for attending to all the questions. It was really nice to have you here with us this day. And I would also like to thank, the whole audience for being with us, for encouraging us, inspiring us, supporting us through this Igenomix Foundation webinar series, which was dedicated to Middle East and Asia Pacific audience. It was wonderful to have you with us for all these episodes. Thank you very much, and I'm sure you will not miss joining us again on 3rd of September for GIF Symposia. You must have received the notifications pertaining to the same, and I'm sure you will receive the reminders after a few days. So please be there with us on 3rd of September. Thank you very much, Nasser, and thank you very much, this lovely audience. We'll miss you till we again come up with an idea of a new webinar series. Wonderful to have you always here with us. Thank you.
Thank you.
Thank you. Bye.